Happy Friday, everyone. This is Ray Pettin from the Center for Care Innovations. Welcome to CCI's Raven e-learning series. The Raven e-learning series has been developed to highlight, hold on one second. The Raven e-learning series has been developed to highlight technology solutions that address priority areas that have been identified by safety net provider community. Raven has been developed as a CCI learning laboratory specifically for the safety net. To join Raven and take advantage of all the platform has to offer, please visit raven.careinnovations.org. The series is designed to be a learning opportunity for folks, and we encourage attendees to engage with our faculty during this session. Please enter anything that you want to engage in the chat room, and I will act as a moderator against the questions. Or when we get to the question and answer period, feel free to unmute yourself with *6 or by using the utility that's built into Zoom, and you'll be able to ask your questions directly. We're looking forward to a great afternoon, I think, taking a look at some interesting technology. When you come onto Raven, you'll have an opportunity to read about key features, explore case studies, think about who you might want to chat with who are actually safety net providers using a particular technology. You'll be able to email a solution partner directly. And should you want credentials to get onto a test system, we would also allow you to do that by sending a request to access a particular test instance of an EHR. We're also a learning community, and at raven.careinnovations.org/e-learning, you'd have an opportunity to take a look at previous e-learning and also register for e-learning sessions such as this coming up in the future. We've done several, one around e-consults, one around social determinants, one around texting, one around interoperability, and the inventory is growing on a regular basis. So please feel free to go to raven.careinnovations.org to become a part of our learning laboratory and to become a part of the community of CCI's learning community across the board. Today's session is focused on community-centered design, and we will be discussing how to maximize cross-team collaboration by including your community partners, thinking about and understanding the value of face-to-face data collection, and using data analytics to improve your understanding of different community needs, and understanding, in this case, the different needs between urban and rural. So I'd like to welcome the faculty today, especially Chelsea Corson. She's the PI specialist for performance improvement at OSF Healthcare, which is a safety net provider in mid-state Illinois. Jennifer Moore, who's a senior implementation manager with Patient Wisdom. Tom Perry, who's involved as the director of sales at Patient Wisdom, and Greg Meckel, who is the founder and CEO of Patient Wisdom, the platform that underlies what OSF Experience has been in their evaluation and deployment of the platform. With that, I'd like to turn it over to Chelsea, and I will stop my screen share and allow her to share her screen so that she can share with you exactly what's been going on at OSF Healthcare. Chelsea?
Thank you, Ray. I will bring my screen up now.
And Ray, while she is doing that, we're getting some background noise. If everyone can make sure their phone is muted.
Yeah, please mute your phone.
Okay, can you see my screen, Ray?
We can.
Okay, so thank you, Ray, for the introduction. I'm Chelsea Corson, a Performance Improvement Specialist with OSF Healthcare here in Central Illinois. And we worked closely on some work around community health with Community Wisdom. And along with presenting with me will be Greg. Greg, do you want to introduce yourself?
Yeah, sure. Thanks, Chelsea. Hi, everybody. I'm Greg McCool, as Ray mentioned, founder and CEO of Patient Wisdom, and give you a little bit of background before diving into the details here. A broad overview and then some really good detailed work from Chelsea.
Okay. Okay, so some background on OSF. We are a faith-based organization. So we aim at serving with the greatest care and love. And we are a large healthcare system. We have about 13 hospitals in all of Illinois, as well as one hospital in Michigan. We're mainly in central, eastern, and western, with one hospital in more southern Illinois, and then we're also in northern. And our hospitals range from urban settings, where I am at here in Peoria, Illinois, where we have over a 600-bed hospital. And then we have very small rural markets, being those in Mendota and Monmouth, where we're closer to a 25-bed hospital, and very, very small towns in rural areas. So this work that we did really kind of highlights the difference between our service areas. So a big part of OSF Healthcare is OSF Innovation, and that is a division that I work in. And OSF Innovation really has been focused on 4 areas for the past couple of years. Those being advancing simulation. We have a pretty extensive simulation center here at what we call JUMP here in Peoria. And we are also working on aging in place, where we're aiming at being able to provide those 65 and older an opportunity to stay in their homes for longer, as well as more for those with less, or those living at or below the poverty line, and being able to make sure that those determinants are no longer a factor in their outcomes as far as health. And then radical access to care is our last really large focus area, which we've defined as rural, given that the majority of our markets are rural. And those meaning outside of an urban area. We define them looking at population density as well as RUCA codes to define our rural areas. And it's how can we make sure that living a far distance away from others and healthcare, how that can no longer, that's not an access problem as it comes to health outcomes.
Yep. Great. And Chelsea, if you wouldn't mind, I'll just sort of say next slide. I just have a couple of things to share with the group here, so appreciate you driving. But our company is called Patient Wisdom because that's all I had in my head when I started it. But we now have, as you can see, 3 solutions: Patient Wisdom, Provider Wisdom, and Community Wisdom. And I'll just quickly touch on the other 2 before getting deeper into Community Wisdom. So what we do with Patient Wisdom is we make it really easy to find out what matters to patients as people, and we get the information boiled down into a way that every member of the care team can view through the electronic health record, so they can look at this information for 15 seconds, go in to see the patient, and do their job. With Provider Wisdom, we're focusing on the people who are delivering care or supporting them, basically the folks on the front line, and helping the organizations understand what matters to them so they can create a responsive ecosystem and enhance real alignment and address burnout and streamline work and care by listening to the people that are doing the work in the care. And Community Wisdom, what we're focusing on today, we're all about trying to understand what matters to people who live in the community, whether or not they are your patients, whether or not they're active patients, so you can either develop or partner with programs that people would actually use. And the line of continuity that runs through all of these is that we're pretty convinced that we can literally transform both the experience and the delivery of care just by listening to the people involved. And I should also say that with Community Wisdom, it was actually built, kind of born at OSF. So it's great to be doing this with Chelsea. They had brought us in to start with Patient Wisdom and they said, you know, we've got some problems we're trying to solve and understand in the community. Can you do what you're doing with the patients for the community? And that's how we got the idea to do Community Wisdom. So we'll talk a little bit more about that. Chelsea, if you wouldn't mind going to the next one. I think this is something everybody recognizes, but it's worth pointing out. Healthcare in and of itself accounts for about 10% of people's health. So we know there's a lot more to attend to in terms of social and personal determinants, if you will. And so that's kind of embedded in our thinking as we do the work with Community Wisdom. And Chelsea, the last one of mine here, I think in terms of the overview, we have 3 use cases from our work with OSF, and we devoted a lot of attention, both teams, to this partnership in terms of proving out the power of the Community Wisdom approach. The first use case was OSF had bought a hospital that was closing in a rural community, and they were enlightened enough to say, you know what, if we build it, I'm not sure they're going to come. So they worked with us to find out what mattered to people who lived in the community. And I'll give a little bit more detail about that in a moment, but it ended up in a big shift in where they wanted to put their resources, and it sparked a whole new health initiative with sustained community involvement. The second use case is what Chelsea will be focusing on, looking at both kind of perception and reality being what the community members thought is what we labeled reality there, to help align the resources and the activities and drive innovation. And then the third use case we won't be focusing on today, but just to let you know that we worked with OSF to implement their community health needs assessment in some of their communities. And that's something that, as you likely know, every nonprofit health organization in the country needs to do one of those every 3 years to maintain their nonprofit status. So that was the third use case. So Chelsea, I can go sort of quickly over to Streeter and then turn it back over to you. So we can, I'm going to be, Streeter is the rural community that I mentioned, and let's just skip ahead to the next slide here, just a visual. And I just want to highlight a couple of things. One of the aspects that the folks at OSF were a little bit concerned about, if they went ahead and took our open-ended approach to asking people in the Streeter community, what do you need? They were worried they'd say, I need my hospital back. And of in this case, I think there were 312 people that we worked with in the community. Only 10 of them said they'd like to see a hospital in the community. So that was not their biggest issue. They were really focused on cost and price, on being able to get to where the care was, and they also said, they told us that they saw the YMCA as the #1 health resource in the community. And so with that, and Chelsea, if you just go to the last one here, OSF ended up redirecting $1 million of funding out of what they were planning to do in that facility that they had bought, the hospital that was closing, and moved it into an investment in the YMCA. So they created a joint program there, and it's been a tremendous success. So just by listening to the perspectives of the community members, their sense of needs and assets is what sparked this change. And what we're doing, just to be a little bit more specific with Community Wisdom, is it's a digital site, it's a website, and patients can use their own device to go on that, and they share a little bit about what's important to them first as individuals, and then they focus on the community. So instead of saying, hey, what are the, here's a list of community resources, what are the top 3? We ask them, what are the main community resources to foster health in your community? and they're generating those from their own knowledge, which is going to be different from any professional knowledge, if you will. And then we're able to boil that information down and share it with the teams. So Chelsea will get it, deeper into that kind of work in the use case she'll be discussing, where we were able to look at both what the community members thought, but also people who were trying to help the community members. So I'll turn it over to Chelsea now. Thanks very much for driving there, Chelsea.
Yeah, no problem. Lots of great work that's happened in Streeter and that continues to happen in Streeter. Where Community Wisdom really helped us is in a program called Complex Solution Innovation, or we call it CSI for short. And we've been tasked by our executive cabinet to focus on 3 of the 4 innovation opportunity areas, being aging in place, radical access to care, and more for those with less. So a lot of focus on social determinants of health in this space and community health overall. So really our objective is to discover the science necessary to revolutionize healthcare system into one that offers value via equitable, optimal outcomes to all who seek care, to where whether you live in a rural area, you're over 65, or you may be in a lower income situation, that doesn't define your health definition. So when we started this work, as you can imagine, they were very large areas of focus. So what does radical access even mean? What does rural mean in the sense of how it impacts your health? Same thing with aging and more for those with less. It's very broad. One could do years worth of research just on food insecurity alone. And we didn't know in our communities what was the most prevalent and where we should start. At the very beginning, we did lots of literature reviews and then dug into, our past community health needs assessments. And then we looked into community available data, from the CDC, Feeding America, et cetera. And we were able, with the help of our advanced analytics team, create a random forest model that then is populated with different variables. Those that are listed there were pulled from data points that were available to us within our communities, and we were able to bring it down to a ZTCA level, so a little bit less than a zip code, and then break it apart into these different focus areas. So for those with less, we looked at those that qualified for Medicaid or that are on Medicaid. For aging in place, we looked at those that were over the age of 65, and radical access, we looked at those that live in a rural area defined by population density and RUCA codes. So we looked at that as all of our service areas, so quite broad. It ends up being the majority of the state of Illinois. And from there, we were able to run this model against QALYs and DALYs, or what determines as these variables, which ones have the most impact on a person's quality of life, life expectancy, and premature death. And in doing that model, it's able to tell you what has an impact on either a fluctuation as a positive or a negative impact. So from there, what came to the top from all of that data analytic work were these things. System integration, really being healthcare in the sense of getting to diagnostic appointments on time and in an early manner, their distance to and from prompt cares as well as hospitals, transportation, whether or not a person owns a car or even has access to transportation in their area, mental health, social environment, the feeling of loneliness or isolation. Built environment being the community itself, where people live, as well as the sidewalks, the parks, the access that they have to exercise, food insecurity, and really health literacy, whether or not they have not just a high school diploma, but the understanding of their own health and what impacts that. So from there, as a CSI program overall, we then needed to narrow down where we were going to do this work at. Where would our test beds be at? Where could we dig in and understand our communities a little bit more? And with us having 13 different hospitals, we had 13 different decisions to make. So we narrowed down to 3, what we call innovation outposts. And those for us are Peoria, so where I'm located, it's an urban setting, and we wanted a location in serving an urban population. And then Pontiac, which is a little bit smaller than Peoria, but and is considered rural, and then Monmouth, which is very rural and quite small. They have a rural health clinic within their hospital, and their population is less than 10,000 in the town, and then the county is pretty small as well. And Pontiac has a very large geographic area, and we have many clinics and locations that may only have a population of 1,000 people or less. So those outposts work with OSF Innovation as well as the CSI team, and they're where we have conducted a lot of our research and where Community Wisdom came in and did a lot of our collection of what we call a voice from our community. So then our next step after we chose where we were going to conduct our research was then deciding what type of voice we were going to collect, and then how Community Wisdom could really help us do it faster, better, and more accurate and precise. So we, on the Complex Solution Innovation team, we have human-centered designers where they, as well as aligns with Community Wisdom, really take an open-ended approach to questioning, to where it's natural, you're not leading anyone in any way to answering a question. So it's very conversation based. And Community Wisdom then we were able to use their platform to ask these questions. So they're very broad. We asked, really tell us more about each of these things that are listed, what causes a difficulty or trouble in your life. And then we asked this to 3 different sections of people: the community, patients and non-patients, and which Community Wisdom played a huge part in that, because it ended up being over 1,000 people. And then with it being qualitative research, as you can imagine, the amount of text that is and information is quite large. And then we also surveyed our community agencies, so our leaders within those community agencies in those 3 locations, Peoria, Pontiac, and Monmouth. And then we also surveyed our own mission partners. And we really wanted to be able to see what was the perception of those within healthcare on what the issues were, those in community agencies, and really the need to partner with them, because community health is really where their work is, and healthcare, we're just really getting our feet wet into community health and seeing them as a major partner in doing this work. And then really what are the true feelings and experiences within our own community. So our community voice collection really just ran from March to April. So it was a quite quick turnaround. And through this, we deployed the survey excuse me, through email, social media, and then we had to go in person and do collection. Social media and email did great in our urban setting in Peoria. We had quite a few responses right away. But then after about 2 weeks, we realized in Monmouth and Pontiac, in our very rural areas, it really wasn't picking up there. That was a huge learning point for us, that wasn't a way that those rural communities respond. So we ended up taking a boots on the ground approach, and many of us from the Complex Solution Innovation team, our marketing team, healthcare analytics, we really are cross functional, and we were able to go and enter our communities, go into our community agencies, talk to people that are at the food pantry. We sat with people in the food kitchen and in the soup kitchens, and we're able to have conversations with them about their lives. And through that, we were documenting within Community Wisdom, and then Community Wisdom there on the back end was able to code and look at really what are the trends and what are people saying. We got a lot of valuable, not just information, but just experiences of our own by being there in person. We even went to, in rural areas, there's still not that large amount of community agencies. So we went also to schools. We went to the bus station if they had one. We went to local diners that it was the hotspot for a lot of farmers to stop in the mornings. And from there, we learned a lot of really great information that in no way we could have learned any other way. And then Community Wisdom allowed us to have a large magnitude to meet a very high sample size number. Otherwise, we would have had, we maybe would have been able to talk to 100 people. Instead, we were at over 1,000. So then within our mission partner and community agency voice collection, Community Wisdom also helped us with that. We were able to deploy the survey across our outpost to mission partners, both frontline, to those that do not interact directly with patient care at all times, and to be able to see what are they seeing as issues, within patients or in the services that they provide. And we got a great response there. And then we also then sent it again to community agencies, so you can see just some of those, being the Center of Prevention of Abuse, the Salvation Army, public health departments. We also talked to the police in each of the outposts as well, because they experience a lot of those social determinant issues, where those that are they may have mental health issues, and then they're constantly back into the system, or they don't have stable housing, and again, then they end up back in the system. So we got a lot of great insight and voice from them as well. And then as far as, the analysis process, so Community Wisdom did a lot of looking at what are the themes and sub-themes, and they were able to code what people were saying. These were sometimes paragraphs upon paragraphs of things that people wrote, or that we were in person doing an interview and had paragraphs of written information that was sent to Community Wisdom, and they were able to tease that apart and make a meaningful report out of it for us. And then as the CSI team, we all came together and reviewed those themes and sub-themes and segments and all the raw data, and we're able to look at, really what is the top 50% of what people are saying in those tell me more questions about, is it transportation that is causing you the most issues, or is it food, or is it housing? And then from there, just to highlight one of the many insights that we learned was the disconnect between, the community mission partners and those agency advocates, being those in the community agencies, that mission partners and community agencies had transportation. That is the biggest issue. However, the community members really it wasn't reflective to them. To them, food insecurity was actually higher, and, as well as other things. So then being able to see the different perspectives really said a lot to our leadership then going forward to say what we needed to work on and why. Then the CSI program, overall, our team, it's multidisciplinary. We came together, our human-centered designers, performance improvement specialists like myself, healthcare analytics. We had all, and then those in the front line from our outposts that work as mission partners in our outposts. We then did a social science approach and created really a hybrid. It's a triangulation to where we took qualitative data, which our healthcare analytics pulled a lot of that modeling I spoke about earlier, as well as other data points within our outposts of really both internal data within our EMR as well as publicly available data. And then we were able to take that qualitative data from Community Wisdom, as well as then current state of what is OSF together. We're a large system. What are we doing for these populations in these areas of food insecurity, built environment, social isolation, mental health, transportation, et cetera, and what are community agencies doing, digging all the way down to every program that they offer. And we took all of that information together and we were able to create what we call how might we statements. It's a human-centered design approach to be able to take all those pieces of information and say, where should we target? Where should we innovate around? And within Monmouth, Pontiac, and Peoria, we were able to create 33 really large opportunities or focuses, how might we statements in Peoria, 19 in Pontiac, and 17 in Monmouth. And this really shaped our work going forward. So just to give, kind of a quote or a background, our sponsor or leader of this work is Dr. Sarah De Ramirez. She's our Chief President, Vice President, Chief Medical Officer of Clinical Innovation here at OSF. She's also a professor at the University of Illinois College of Medicine. She's done a lot around global rural health throughout really places throughout the world, and we're very fortunate to have her here and leading this work. And just a quote from her in our partnership to be able to do that triangulation and have all of this evidence to then back our work is, our partnership with Community Wisdom gave us a much greater insight into the needs of our community that we serve. The digital platform allowed for us to ask our most vulnerable populations qualitative questions to gain a better understanding of their greatest challenges. We would not have been able to assimilate the volume of information in a constrained timeline without the expertise of Community Wisdom, and their support and our research has not only provided a shape to our work, but ultimately has helped us improve our communities. So what she means by the shape of our work is all of those how might we statements that really were driven a lot from what we learned in the community, is then our portfolio, and that we've been working on from the last spring to now, and we made really great strides. So the CSI program, we work on system integration and system extension. We were able to take those how might we statements that talked about how I feel like I need an advocate when I enter the healthcare system, that it's so large and complicated, I don't always know the right place or know the right things to say. And even just having access to get in alone really has driven our work towards planning towards a community health worker program. And then over on the other side, social connections and system extension, isolation in our rural communities was huge. We learned a lot about those that are living alone, those that may not see others in many, many weeks. The rural farmers that, their farms are going away when they have a hard season with a long drought, that experience of really dipping into depression, into mental health issues, deriving from feeling lonely, as well as the loneliness experienced in our populations of more for those with less, that just feel alienated because of their social status. And then those that really we found to be the most vulnerable were those 65 and older living in rural areas, and understanding what exactly, how can we provide them more connection to their community, to feel more supported as really they come towards the end of their life. So that then formed a part of our program where we ended up partnering with the University of Illinois at Chicago, and they have an innovation center there. We, in the past year, I've hosted 2 classes and a lab, all focused around how do we create a solution or innovative prototypes for 65 and older in rural areas to combat that social isolation feeling of loneliness and being physically isolated as well as emotionally. So that work has been going on for a full year now, and we're continuing that partnership going forward, and really being able to have really over 15 different prototypes come out of that class of different things, ranging from a social bot that talks to you, to how do we, bridge those intergenerational gaps through technology as well as existing technologies. And then in the center there of our portfolio is what we refer to as test of change. We identify many things within housing being an issue, food insecurity being that of I may not know where my next meal is coming from, as well as I don't have access to the food that meets my dietary restrictions. I rely on a food pantry, and I go there and I may get a bag of chocolate sauce. That was actually a direct quote. A diabetic patient was getting a bag of chocolate sauce at her food pantry because that's all they had to give her. So that type of information drove this. And then transportation was an issue in our rural areas like Monmouth. There is no community or public transportation. If you don't have a car, you're really not going to get anywhere. And then having to rely on friends and family maybe to drive you places, and even then that may not happen if you're isolated from others, and those that used to live in your area have moved away for jobs or other opportunities. So that has driven our work for the need to screen for social determinants, to identify the needs within our patients, and then to continue to come up with innovations around these different areas to then provide our patients directly when they come in to visit us, so that they have opportunities to change these areas of their lives. And then just overall, it really drove the need for us to be able to connect better with our community agencies, to partner with them, and that way we are all together as one community working towards a better overall health. So that we all can see the benefits and impacts of the work that everyone's doing together instead of keeping it siloed. And then we also have other work we're working on between the Medicaid Challenge. Socially Determined is a data analytic platform that we're able to pair with things like this voice that we gathered, and then Conduit being a community platform for data as well as best practices when it comes to what has worked as community programs and what hasn't. And then again, back to that community partner with technology such as Pieces Iris, where it allows those in the community to know what's available to them. We also learned that through the help of community wisdom, that those in our community weren't even aware of some of the programs that they would qualify for, or that they even had locations in their communities, just because it's not necessarily advertised. But overall, all of this work, lots of detail, lots of great insights that we learned from really amazing people that opened up really their lives to us through the help of Community Wisdom and helping us shape those questions and working with our human-centered designers to provide that experience for those we were asking these questions of. And then in a month turnaround, have thousands of sets of coded information for us to quickly be able to form how might we statements inform our portfolio. And we also were able to write about 100-page white paper on all of this work as well, and everything that we learned. But Community Wisdom definitely was a big part of being able to be precision guided in this work, and also be able to do it very quickly. And that's all I have. I don't know, Greg, if you want to add anything to the work that you did with the CSI program.
Well, Chelsea, that was a great overview. Thanks. To me, what really is highlighted in your description is that we found, really tight alignment through this open-ended process. Really tight alignment between the people working at OSF that are meant to be helping folks in the community and the people at the community agencies that are supposed to be helping people in the community. The only problem was on a couple of pretty important issues, they were, very, very much different from the people they were supposed to be helping. So the process and the logic of asking all three of these audiences, I think was super helpful. And we all learned a lot from that, I think. And thank you for your great overview here. Ray, I think we'll turn it back over to you.
Okay, Chelsea, Greg, yeah. Overwhelming. Absolutely overwhelming. That was superb. One comment came in to me while this was going on, just highlighting what a great job Chelsea did of connecting tech with design thinking and a robust community approach. I mean, it's something that I think the safety net is looking for very broadly. And it's kind of interesting that you mentioned socially determined, because they're the next Raven e-learning session that'll be coming up here this next month. For everyone's information, the video will be available as soon as it's compiled. It'll be available through the raven.careinnovations.org website, and slides from this presentation will be emailed to those folks who have registered, so you'll be able to refresh your memory on what Chelsea and Greg shared with us today. I think they did just a super outstanding job. We're now open for questions and comments. Please use the chat window if you feel comfortable with that, or use *6 and unmute yourself and ask directly of Chelsea and Greg. So, folks, please chime in. You two did such a great job that people are having to think about what to ask. I do have one question to start it out. I noticed, Chelsea, that the whole time frame that the platform ran to gather the information and get a data set of 1,000 and the work you were doing gathering data took about 2 months, I think you mentioned. How much pre-work needed to be done in order to be able to launch that for the 2-month data collection period? And then once your data collection period ended, how much post work went on to get the data into something that became actionable?
So that's probably a funny thing that I think Greg will laugh about because it was CSI had been thinking about how we're going to collect all the voice that we needed to know and have a large impact. And with their work with Streeter, it really highlighted their ability to touch a lot of members in the community. And we had a few preliminary conversations with them a few months prior, but then it came down to we're ready to collect voice, and it was about 2 weeks that we worked with Greg and we created the questions, and they were able to quickly deploy it and send it out. And then afterwards, the CSI team got all of the results and coded questions from Community Wisdom. I think what's great about them is they work real time. So as surveys came in that were completed, as we completed interviews, they then took those immediately and were starting to code them. So then there really wasn't any lag time where we were waiting on them for any type of output of all of that information in the coded responses. We were then able to quickly take that and start a triangulation, which we did in a week.
Interesting. Joanne Benham asks a question. I wondered how many people were involved in the information gathering process.
In the gathering of information, as far as those of us that were boots on the ground, there were kind of a small team. Actually, there's less than 10 of us went out and gathered all of this, and then from Greg's side, I believe there was only 2 coders that we worked with, and then we worked a lot with Jen. But yeah, a team of 10.
Thank you. Other questions and comments from the community? It's another voice for you to listen to here, Chelsea. The community of safety net providers.
Really very important voice.
Yes.
We believe that. From Jennifer DeMond. In discussing your results, you highlight the discrepancies between the community response and the agency/partner responses, particularly around food and transportation. You suggest, though, that the community voice is the truth. Why didn't you dedicate all of your focus and energy on this population exclusively?
We did not focus everything on that population exclusively, no. It was really broad spread between all 3 of our outposts on that disconnect. And the transportation thing, it was kind of nothing new for us. That we expected our mission partners to say that was an issue, with missed appointments and things like that. And I think what really describes it is the nuances of what they meant by transportation. So to mission partners, they felt like the patients didn't have rides, that's why they weren't coming, or they didn't own a car and they couldn't get there. Or that's why they would have to come late or leave early, et cetera. And on the community voice, it was the opposite of, no, it's your services aren't provided at a time when I can get off work to come there, that you don't offer an opportunity to integrate within my own life. I'm having to work around your schedule, your office's schedule, to get into my primary care visit, or to get a mammogram, et cetera. So it was that type of view, and we, as a part of CSI, really wanted to continue with not just narrowing down to just working on transportation or just working on food. We wanted to make sure that in food and housing and transportation, those areas, that we then had an opportunity to be able to deploy those. And that's where that community health worker program that we're planning for comes in. And then that's also where our partnership with the University of Illinois at Chicago also comes in. So we have continuous new opportunities coming to where students that are brand new at looking at challenges like this come up with really creative prototypes and solutions for us. So we now have an influx of new ideas, and then we have our aim at what we can do for those struggling with food, transportation, and housing, and what we can provide as a healthcare system and partnering with our community agencies, and then being able to deploy those both within those patients that we see and through our eventually a community health worker program to dig into those populations that we don't necessarily always touch.
And if I could just add a little bit onto that, to Jennifer's question, the reason to look at all three audiences, if you will, was to try to get a handle on alignment. And I think the insights that were drawn from the results, just help shape the direction for the professionals, if you will, in terms of understanding better what the issues are and how their lens is a bit different. I mean, everybody knows that, but to kind of see it in terms of the responses, I think made a big difference.
Mm-hmm. Thank you. From Vinu Alec, while boots on the ground are important to the process, is there a way, or would it be effective use of the Community Wisdom platform to collect community voice without such a labor-intensive approach to boots on the ground? Just trying to understand how to translate, kind of the big system OSF. We have some resources, we can put them on the ground, to some of our safety net partners here in CCI's world that are much, much more resource constrained and might not have the ability to deploy staff in a manner similar to what OSF was able to do.
Yeah, Chelsea, I'll maybe start on this one, and then please chime in. Normally, Vinu, that's what we do. We don't put boots on the ground, so to speak. We will reach out through social media, digital media, other ways of inviting people, creating posters or postcards or what have you. We will work with the community agencies, or we do work with the community agencies, and maybe we'll put a tablet in the WIC office or at a food pantry, that sort of thing, in case people don't have their own device. But generally, that's the way it works. I think what Chelsea was pointing out is that in the super rural communities, that there wasn't enough uptake through the kind of purely invitation and then go on your device and do it method. So that's why they reached out in person. And Chelsea, I just want to make sure you have a chance to respond to that too.
Yeah, and that's exactly right. It worked great, social media and targeted email for our urban setting in Peoria, but then in Pontiac and Monmouth, they're very rural. We have lots of locations without internet. So we were taking, hotspots with us in order to keep an internet access. And we also didn't want to just hear from our patients ourselves. So we could have sat in our rural health clinic and surveyed everyone that came in. But rather we wanted to be out into the community, and it was a big trust building piece as well, was putting a face on these questions and being able to have the experience of truly having those conversations with individuals. And I think where it definitely was labor intensive, and we are very resource constrained, that team of 10 is when we, I guess it's 10 people, but you don't have 100% of their time. So it's 10 people with maybe 0.2 of their full time dedicated towards this. So they would have went out and maybe were able to give an hour and then come back in. So we understand that resource constraint piece. It became then we have a short amount of time to get this done. How are we going to do it? So it became that boots on the ground approach. And when we went out into each outpost, it was about 2 to 3 people went to Pontiac, and then 2 to 3 people went to Monmouth, and 2 to 3 people went to Peoria. So they were spread.
Thank you. Last question, we're trying to be respectful of everybody's time, from Jennifer Devon. Sorry if I missed it, but what type of solutions did you prototype/use for seniors suffering from loneliness and/or mental illness in rural areas other than chat rooms?
So our innovation lab and class within the University of Illinois at Chicago, they then use a human-centered design approach as well. And they were able to, in the past year, create 15 total prototypes. So they're currently being worked to high fidelity, so they have not been deployed yet. They're continually being worked on. There were apps created. There were social bots that were created that were an interactive type of product that sits in someone's home that is able to detect whether or not they have spoken, whether or not they've left their home, whether or not their things that they're saying are positive in their behavior. And they were also worked on programs that were for more of the rural community focus, being able to bring generations together. So those that were 65 and older, and then those that were 30 to 60 range, and then that high school age, college age, kids being able to integrate within the generations and providing different, whether it was services or opportunities with each other, like things like ride sharing, rent a grandparent, rent a grandkid, that type of stuff. So some pretty different things, but they're continuing to develop them. So they take quite a few iterations, and some of them are included in some manufacturing type of things. So they have not been deployed yet, but those are the things that we're working on now.
Great, thank you. Well, we're at the close of our time together today. I really have appreciated this point of view. A number of issues I haven't ever thought about, but I think they came out during the conversation. Chelsea, Greg, I can't thank you enough for supporting CCI and our efforts to provide learning opportunities to the safety net, and taking time today, and the amazing work you've done at OSF around understanding the community better and using those data in order to make active decisions. I'm very impressed. The video will be available once it's compiled on raven.careinnovations.org, and the slides will be emailed to those of you who registered for this event. And I'm looking forward to hearing from the community as we move forward together in trying to resolve this problem. And hopefully, if you have any direct questions that you'd like to ask, hopefully Chelsea might be available to you to act as our expert mentor as we broadly think about these kinds of things in the safety net. So have a great Friday evening and enjoy your weekend. And Chelsea and Greg, thank you so very, very much for taking your time today.
Thank you, Ray, and thanks, everybody. Thanks, Chelsea.
Yeah, thank you, Greg, and everyone.
Bye.
Bye.
Bye.